You know, when an older patient in the hospital seems confused, it's so easy to just write it off, right? Oh, they're just sick, or it's just old age. But what if I told you that confusion could be a sign of something way more serious? I'm talking about a medical emergency on the same level as sepsis. That's what we're diving into today, delirium. To really get our heads around this, we need to throw out the old way of thinking. Forget asking, what is delirium for a second. The real question we should be asking is this: what is acute brain failure? Because, you know what? That's exactly what delirium is. It's not some psychiatric problem. It's the brain as an organ failing acutely, just like a heart or a kidney would.
So, to make this real, let's talk about a patient. Let's call her Eleanor. She's 80 years old, and up until now, she's been sharp as a tack. But she has a fall, needs hip surgery. The operation itself, it goes off without a hitch. But then, in the recovery room, her family starts to notice something is just terribly wrong. This person is not the Eleanor they know and love.
All right, so here's our game plan. We're going to follow Eleanor's story to see what this sudden, frightening change is all about. We'll define what acute brain failure really means, explore why some call it the brain stress test, figure out how to spot it, and most importantly, talk about how to manage it. Okay, let's dive right in. Section 1. That first, terrifying moment for Eleanor's family. The onset.
So picture this. After her surgery, Eleanor is just not herself. She's incredibly agitated, pulling at her IVs. She has no idea where she is. She's even talking about people in the room who just aren't there. And here's the absolute key. This is a sudden change. This isn't dementia that's been slowly creeping in for years. Nope, this happened fast, over just a few hours.
So what in the world is going on inside Eleanor's brain? That brings us right to the diagnosis. Okay, so the medical term for what's happening to Eleanor is delirium. And the definition is actually super specific. First, it's an acute, meaning sudden decline in thinking. And it fluctuates, which means it can be bad one minute and then seem a little better the next. But the real hallmark, the number one thing to look for, is a major problem with attention. The person just can't focus on anything.
Now this is so important, because this is where a lot of people get mixed up. Delirium is not dementia. Let's break it down. Delirium hits you like a truck. It's sudden and it comes and goes. Dementia, on the other hand, is a slow, steady downhill slide. And think about attention. Someone in the early stages of dementia can usually still focus, but with delirium, nope, that ability is gone. And here's the most hopeful part. Delirium is often reversible. Dementia, sadly, is not.
And it gets even more interesting. Delirium isn't just one thing. It actually comes in a couple of flavors. What Eleanor has is the classic hyperactive type. Think hyper, agitated, restless, maybe even seeing things that aren't there. This is the loud delirium. It's the one that gets all the attention because, well, it's impossible to ignore. But then there's the other side of the coin. And honestly, this one is much scarier. It's called hypoactive delirium. And the danger here is that it's the complete opposite. The person is withdrawn, lethargic, super quiet. And get this quiet delirium is actually more common. But because the patient isn't making a fuss, it gets missed all the time. Their brain is failing right in front of us, and nobody even notices. So the big question is, why? Why does this happen? Let's dig into the investigation. I absolutely love this analogy. Someone once described delirium as a stress test for the brain, and that just nails it. Think about it. A major stressor, like surgery or an infection, hits the body. And for a brain that's already a bit vulnerable, that stress is just too much. It unmasks a weakness that was already there, a kind of low brain reserve. So it's usually not just one thing. Think of it like a recipe for disaster. You start with the predisposing factors. These are the things that make the brain vulnerable to begin with. We're talking about being over 65, already having some dementia, or even just not being able to see or hear well. Then you add the precipitating factor. That's the final straw, the insult. For Eleanor, her age was the predisposing factor. The surgery, the pain meds, the dehydration, those were the insults that pushed her right over the edge. And if you think this is some rare thing, think again. Get ready for this number. In older folks who are in the ICU, the rate of delirium can be as high as 75%. 3 out of 4. This isn't a footnote. It's a full-blown crisis happening in our hospitals every single day. Okay, so if it's that common and that dangerous, we have to know how to spot it, right? So how do we actually do the assessment? Well, the good news is we don't have to just guess. There are actual tools for this, and the gold standard is something called the Confusion Assessment Method, or CAM for short. It's basically a simple, structured checklist to see if someone is delirious. And here's how it works. The CAM looks for 4 things. First, did it start suddenly and does it come and go? Second, is the person inattentive? Can they focus? Third, is their thinking all jumbled up? And fourth, are they either hyper-alert or kind of drowsy? The rule is simple. You need to have the first 2 things, the acute onset and the inattention, plus either number 3 or number 4. It's a really clever and powerful little algorithm.
So why do we need to be so vigilant about this? Why does it matter so much? Just look at these numbers. If a patient develops delirium in the hospital, their risk of dying is somewhere between 25 and 33%. To put that in perspective, that's right up there with sepsis. Let that sink in. Missing delirium can be just as deadly as missing sepsis.
Okay, that's heavy stuff. But this brings us to the most important and, frankly, the most hopeful part of this whole story. What do we do about it? How do we manage it?
All right, the number 1 rule of managing delirium is what not to do. The knee-jerk reaction when someone is agitated is to sedate them, but that can actually pour fuel on the fire. No, the real first step is to put on your detective hat. You have to find and fix the underlying reason the brain is failing. Is there a hidden infection? Is it a new medication? Are there electrolytes out of whack? You have to find the trigger.
And while you're playing detective, you also have to create a supportive environment. And the amazing thing is, the best tools we have aren't drugs. They're simple, common sense things. We're talking about having a clock and a calendar in the room, making sure the patient has their glasses and hearing aids on so they're not cut off from the world. We need to help them get a normal sleep-wake cycle, get them out of bed and moving around. It sounds basic, but these things are incredibly powerful for helping a brain heal.
And that's exactly how Eleanor's story ends. Her medical team figures out her pain meds are a bit too much, so they adjust them. They get her hydrated, the nurses get her up into a chair, and her family comes to visit. And just like that, slowly but surely, the fog begins to lift. Over a couple of days, her mind clears up, the Eleanor they know comes back, her delirium resolves.
So, we've come full circle, but hopefully we're looking at this with a totally new perspective now. The next time you see a patient who's suddenly confused, I want you to ask yourself this question. Is this just confusion? Or is this acute brain failure? Is this a medical emergency that needs my attention right now? Because knowing the difference, well, that can change absolutely everything.